functional organ. Now, the more recent studies are addressing this. But to get back to your question, Dr. Bradley, I don't know if we have an answer to it. So that patient who is aspirating up front, I don't know if we have very good predictors, at least I don't know of any, very good predictors to say whether they will do well or not with a non-surgical approach, or whether they should be, they're better served with a surgical approach. Yeah. We just haven't addressed those issues in long-term follow-up.
Right, so I just want to say, suppose the aspiration is due to bulk rather than destruction, then we do better with therapy, but if it's due to destruction, you're not going to regrow the organ. The other point is that from my point of view, not my patient's point of view, I think swallowing is far more important than speech. We can replace speech a number of different ways in the patients now that we have TEPs, we have other devices, and eating in public and with your family is a far more important social event in some ways than speaking with a normal voice, and I think we can get very good voice quality. So I talk to patients when we have this debate as to whether organ preservation is as important with regard to speech as it is with swallowing function, which I think is critically important for people.
We've all emphasized the concept of operable and inoperable as a selection criteria. At which stage do you restage your patient, having completed your chemoradiation, to determine, one, have you got cure? Two, when do you now offer the patient for surgical salvage? Because in my opinion, most of them are not salvageable. And then what sort of function you get after that?
If I might answer, sure. Because we have the divine right of PET scanning in the States, we generally reevaluate the patients after the chemotherapy. We get an indication as to whether there's a complete response in the neck. And we do an evaluation under anesthesia for many patients when we put the stomach tube in before radiation, between the induction and the radiation. That allows us to assess the primary tumor directly. And if those are negative, we don't go further with surgery. If they're positive, we reevaluate the patient with the idea of surgery. And we like PET scanning at about 12 weeks because that's when you get fewer false positives. In unresectable patients, we'll sometimes follow them more continuously.
You wouldn't PET your inoperable, quote unquote, unsalvageable patients with a PET at 12 weeks?
We would.
Do they not expect
we believe patients become potentially salvageable with this kind of treatment, in part because the tumors shrink rather dramatically. We've had a few patients in whom there has been no disease in the neck dissection, and a few in which there have been who were originally unresectable but became what I would call nidusectomies, removal of the prior nidus of treatment of disease. In those patients who are truly, base of skull invasion, pterygoid involvement, where you would not venture to do surgery, we don't.
But to be keeping still to hypopharynx, I think the question you have is, if you started with cartilage destruction and operable,
yes,
then you chemoradiate your patient. How do you know you still have persistent disease and or chondronecrosis at 12 weeks?
In those patients who we see continued pain, possible infection, we will take them back to the OR if that continues on further for several more months, or if there's obvious evidence of local progression. We have taken out a few larynxes in patients who've had essentially unremitting progressive ulceration, but these are rather rare. In the induction group. We see them more in chemoradiotherapy with accelerated concomitant boost, but they're usually also in the context of small areas of cancer that are still present. So there have been very few people that have had laryngectomy without cancer being in the tissues. But we do close follow-up. We monitor the patients on a monthly basis. We also take them to the operating room if they have strictures and dilate them at about 6 months. And we do speech and swallowing assessments fairly continuously in them.
Would you like to tell the audience about your stricture kind of prophylaxis and your stricture management?
Yeah,
particularly... Do you encourage the patient to swallow during their treatment, and even though they have a G-tube? that you keep saying, keep swallowing, or do you just say, oh, what the hell, live on your G-tube?
As a medical oncologist, we see the patient for symptom management throughout their radiation on a weekly basis and hydrate them. And during that period of time, we make sure the patient initially sees a speech and swallowing therapist before they go to radiation, and then during radiation, they continually see them, and they're encouraged to continue to swallow and use narcotics appropriately to reduce the pain and the mucositis so that they can, and antifungal, so that they can continue to swallow as long as possible. In the post-radiation setting, with continuous speech and swallowing management, our surgeons have developed a technique where they, with the thoracic surgeons, enter through the peg for people with a severe stricture and actually sound the esophagus up through the peg, and then dilate from above on a wire through the esophagus. And with this, we have about a 3 to 4% peg dependency rate at 1 year in our patient population on or off trial. And so we're very aggressive about doing this in the patient population. I think you have to be. And our head and neck surgeons have become very good at managing speech and swallowing. And in fact, they put all the stomach tubes in our patients during the EUA, so they actually do this as a directed part of their procedure. So it's really important that they get engaged and continue to be engaged with us. And one of the values, I think, in the combined modality setting, in that we all sit together and evaluate the patients as they go through treatment, is that we get to see and hear from the radiation oncologists what their concerns are about how they do the radiation. And our surgeons and radiation oncologists get to see the toxicities and the late effects quite more directly than they would otherwise. So we capture these. There's almost an aphasia when you have a limited engagement in the patient as to what happens later. And it's very important to recognize that. And I think in the community, the radiation oncologists really do take care of a lot of the side effects that they see in their patients, or they're aware of them. But I think in academics, there's a tendency to pass the patient on to medical oncology and to miss some of these long-term problems. I think that's why when we saw people coming up with esophageal strictures and severe dysphagia, we immediately began the process of having speech and swallowing involved. I think that this is really a radiation oncology area, and we're encouraging our radiation oncologists to get involved in outcomes research on swallowing and dysphagia, and to work with speech and swallowing, because that's where a lot of the problems are that we see in our patients.
Petra, would you like to present some of your work on your laser surgery, in that not only have you done early disease, you've also done advanced disease?
So we have done advanced disease in the sense so that 70% of the patients are stage 3 and 4 due to lymph node metastasis. You will find the recent updated figures in the last issue of the laryngoscope, and the experience of the Göttingen group is now 172 cases, partially resected. The majority of the cases of the patients had mobile vocal folds. This means not as advanced primary disease. The oncological results we have had in these patients were recurrence-free survival rate with intact larynx for stage 1 and 2, 73%, for stage 3, 60%, and stage 4, about 47%. And as the function is regarded, the functional results are very favorable. The indication must be correct, and patients had, as adjuvant treatment, radiotherapy without chemotherapy, conventionally fractionated radiotherapy. So this means we had no problems with strictures. Yeah? The failure rate was 3.5% due to aspiration, not due to strictures. And we made the same experience as you did, that it depends on the patient. When you offer a salvage laryngectomy for functional reason, and the patient has an almost normal voice, maybe that the patient decides for preserving the larynx and going on PEG feeding. We as treating physicians see this the other way around. Maybe for us, eating would be more important. So our experience is the same as yours, that patients see this in a different way. But altogether, the functional results with just 3.5% failures from functional reasons are very favorable.
So surgery is an option.
Surgery is, yeah.
For the teeth?
It's part of the treatment.
It's part
in my
of the treatment,
hospital,
yeah.
for example, after the chemoradiation, patients with positive neck are underwent to surgery in the neck and biopsy in the primary site. All patients. Surgery is part of the treatment.
What about those that actually do survive, their long-term quality of life? What do they think of their treatment 1 year down the line, 24 months down the line? We all know that patients, yes, survival at all costs. That's for the first 6 weeks. And after they got past the 6 weeks, they say, hang on a minute, I can't swallow, I can't talk, I can't do anything. And now you get necrosis and your teeth fall out and all these other things. Then they bitch, and then you wonder kind of what is the benefit? So you almost run a psychiatric clinic after a while.
That's true. That's very true.
Well, I think
Ezra.
I think we have to first of all look at the numbers that we're talking about. Clearly, if you and you alluded to this, clearly if you ask patients prior to starting therapy, what is your priority? Almost every study that has looked at this has shown they want to live, and I think most of us would agree with that. Then you have to look at the period post-treatment and whatever that treatment is. I think in the acute period and the period of a few weeks following, let's say, chemotherapy radiation, you're quite right. Many patients will say, well, I'm having second thoughts about going through this, and life is miserable. And actually, we're beginning to look at things like the incidence of major behavioral disorders, major depression, because I believe it's probably approaches 50%, or if not higher. But then you have to look months down the road, and for the majority of patients, if you look 6 months and 12 months, and again, looking at quality of life parameters, looking at functional parameters, the great majority of patients have returned to normal function, and certainly have returned to baseline function. And so when we're talking about those patients who suffer the terrible morbidities, the necrosis, the bad dentition, etc. It's really a minority of patients, and you know, we've heard some of the numbers, and our numbers, I think I would agree with you. They're less than 10% that are PEG tube dependent or that need a laryngectomy for chondronecrosis or something like that. In fact, arguably it's even less than 5%. So I think we have to keep things in perspective. The great majority of patients do return to baseline, and still the majority of patients even return to normal.
Normal, in inverted commas.
Normal meaning they're able to communicate with either normal speech or whispered speech, and they're able to sit down and eat a meal with their peers.
Yeah. One of
Petra,
my
ladies first.
Thanks. For my partially resected patients, I see things much more favorable. Yeah, you must know when you do a partial resection and an adjuvant radiotherapy, no chemo, then function does not deteriorate over time. So this means when you are at the end of treatment, then you come to a stable condition. The failure rate report have already said 3.545%, and patients complain on the long run on the sequelae of radiotherapy. This means on xerostomia. They are able to eat and they can talk. They have no tracheostomy, but they want more. And what the interval between surgery and radiotherapy? I have patients. They use this interval 3 weeks. In between surgery and adjuvant radiotherapy to spend a 2 weeks holiday in Greece. Why not?
Sure.
Sure.
Marshall, you were going to comment before I cut you off.
Oh, it's okay. I was.
I think you have to remind the patient that they're alive with
they're
xerostomia.
Yeah, but you must, this is true. But we don't see, what I forgot to say, we don't see any complications, like chondronecrosis. From this kind of adjuvant radiotherapy. This does not happen.
Let's remember that this is not a randomized comparison.
That's true.
That this isn't a protocol-driven set of patients with inclusion and exclusion criteria. This is a personal experience. It's valid, as a personal experience, but it's not generalizable to the general population. It is a personal experience, as many of the data that we saw earlier today are. And unless you do this in a programmatic fashion, and you have an opportunity to do a randomized trial here, if you do selection and exclusion criteria, why would I